Okay, welcome everyone to today's presentation. Thank you for being patient. This presentation is being recorded. Today's topic is about going to your gynecologist, what to really expect when going to your gynecologist, and when should your daughter start seeing a gynecologist. And is a yearly visit really necessary for every woman? Our presenter today is going to be Dr. Linda Matheson. Before I tell you a little bit about Dr. Linda Matheson, I just wanted to let you know that before we get started, everyone should be on mute. I tried to mute everyone, but if you come in later, make sure you put yourself on mute. In regards to questions, we're going to have our questions toward the end of the presentation, so you can go ahead and put your information in the chat box. I'll be controlling the chat box, and I will give these questions to Dr. Matheson at the end of the presentation. So just to tell you a little bit about 360 Girls and Women, our mission is to provide evidence-based health information and services to girls and women to maximize your complete wellness with a complete life cycle. So 360 represents completion, and part of that information is allowing a woman to flourish and grow and provide them with the tools that they need. And so today we're having evidence-based information from one of our experts so that we can share this information to not only ourselves, but to our children or to our daughters, nieces, and all the women in our lives that we care and cherish. 360 Girls and Women, we also offer packages to address health needs for girls and women. So if you are interested in learning about how to improve your health, you can contact us at complete@360girlsandwomen.com. If you have information or questions or concerns for Dr. Matheson, you can also send them to me and I'll reach out to her. So Dr. Linda Matheson received her Doctor of Medicine from the University of Rochester, New York, and completed her residency at Dunbury Hospital Residency in Obstetrics and Gynecology program. She served as clinical instructor of obstetric and gynecology in Louisiana State University School of Medicine. She's a fellow of the American College of Obstetrics and Gynecology and currently works at a private practice, OBGYN Virginia Center for Women. Dr. Linda Matheson is married and has 3 children, Jessica, Jacob, and Jennifer. She enjoys crocheting, she likes to travel, and also she loves to cook. So today I welcome Dr. Linda Matheson.
Good afternoon, everyone. Thank you, Sue Ellen. My name is Dr. Matheson, and I am an OBGYN in private practice now for about 22 years. And we're just going to spend a few minutes talking about the important elements of a yearly exam, why it's important to go every year despite myths you may have heard. We're going to talk about important tests, various birth control options leaning more towards non-hormonal methods, and healthy choices that you can make to improve your fertility. Okay, so first question is it important to have a yearly gynecological exam? Yes. When should you start that exam? I would say maybe about 2 to 3 years or so after a woman has started her menstrual cycle. That doesn't mean when she comes in, we're going to do a full pelvic exam. In fact, I do not do a pelvic exam until a woman is 21 years old or she has become sexually active. I think what keeps some young women away from going to the gynecologist is they're afraid of the dreaded pelvic exam and the speculum that we use to examine the pelvis. But there's really no need to do that until the age of 21. We can do a breast exam, check the abdomen, listen to your heart, check your thyroid, but there is no need to do a pelvic exam until the age of 21 unless you're having a problem. For example, if you're having pelvic pain or an abnormal discharge, then we have to actually examine the area that is in question. So let's start off with what entails what encompasses an exam in a younger woman. And this would really be for women the ages of 13 to 18. So we talk about what is a normal menstrual cycle, what is how many days of flow you should have, how much pain you should have, or what is normal amount of pain. We talk about sexual activity and what you can do to prevent sexually transmitted infections. We talk about taking a daily multivitamin, getting regular exercise, talk about getting regular dental checkups, talking about the importance of a daily breast exam, and also talk about vaccines, including getting a flu shot every year. When we move to women in their 20s, specifically 21, that is when we do the first Pap test. Pap test used to be every year starting at the age of 18. It is now every 3 years in the 20s, and then we move into every 5 years, including HPV testing, starting at the age of 30, and we'll get into that shortly. So when a woman comes in and she is in the age group of 19 to 20, we talk about different things. We talk about getting a Pap test every 3 years. Now you might wonder, why are Pap tests now every 3 years as opposed to every year? As time has progressed, we have learned more about cervical cancer. It is a slow-growing cancer. In fact, it takes many years from the time you have a mildly abnormal Pap to have full-blown cervical cancer. We realized that we were doing many unnecessary tests and procedures on women that not only led to anxiety, but also could lead to issues with becoming pregnant and maintaining a pregnancy. So now Pap tests are every 3 years in a woman who is in her 20s, and then it is every 5 years, including an HPV test for women in their 30s. For women who are in their 30s, make sure that when you go in for your annual exam, your gynecologist is not only doing a Pap test, but she's also doing an HPV test as well. So when you go in for your yearly exam, at least for my patients, they get a form asking about the family history of uterine cancer, ovarian cancer, breast, colon, pancreatic, and other cancers that have a genetic component. You might notice, if you get this from your gynecologist, that there is no question anywhere on there about a family history of cervical cancer. And that is because cervical cancer is not a genetic type of cancer. It is caused by the HPV infection, or human papilloma virus. Some women will say, well, a lot of women in my family have cervical cancer. Well, a lot of women in your family had the HPV infection, which is only obtained through sexual contact. The HPV is a powerful test. That test can predict your chances of getting cervical cancer. Essentially, if you don't have the HPV infection, your chance of getting cervical cancer is almost zero. So if your Pap test is normal, and you're in your 30s and above, and you don't have HPV, the chance that you'll get cervical cancer is almost zero. So you might ask yourself, some patients have said, well, if I don't have HPV, well, I'll never have to have a Pap test again because I'll never get cervical cancer. Not quite, because HPV is transmitted only sexually. So even if you don't have HPV, things can change, your partner might change, and you can get the HPV infection. And that could increase your chance of getting cervical cancer down the road. Why is it that we have chosen 5 years for every Pap and HPV test? So you go into your gynecologist, your Pap test is normal, and you don't have HPV. If, for example, that evening you have an sexual encounter, and you are infected with the HPV virus, it takes about 5 years for that infection to cause enough change that it would actually be picked up on a Pap test. So that's why that interval of 5 years was chosen. The Pap test is a subjective test. It is subject to the person who is reviewing those cervical cells under a microscope. Maybe they missed something. It's also subject to the collection. Maybe the provider that collected the cells from your cervix missed an area of the cervix that had the abnormal cells. But the HPV test is not. It is an objective test. These cells are simply run through a machine and it looks for the DNA. Either you have it or you don't. So the HPV test is actually a more powerful test. There are some places where they don't even do the Pap test. They start with the HPV test. And if your HPV is negative, they don't care about what the Pap test shows, because in their mind, you'll never get cervical cancer. I have had patients, I had a patient maybe about 4 years ago, only 32 years old, and her Pap test was normal. And she had HPV, which prompted me to do more further testing. And it turned out that she had cervical cancer. And as far as I'm concerned, that HPV test changed her life. So make sure that over 30, you're getting the HPV test. And on a side note, you might wonder, why are they not testing women in their 20s for HPV? It's because as of right now, over 90% of both women and men have HPV infection. So it's very common. And also, women in their 20s typically have not had the HPV infection long enough for it to have caused issues. So we're not really concerned about women in their 20s as to whether or not they have the HPV infection. Okay. So we're talking about women in their 20s and 30s and their testing that they should have. So that includes the Pap test. We also recommend women get testing for STDs. Half of all STDs are in women who are younger than 24. You might say, well, you know, what about if I'm in a monogamous relationship and I feel normal? The most common symptom of an STD is actually nothing. So the fact that you feel perfectly normal has no bearing as to whether or not you get an STD test. Some women say, well, I'm married, I'm monogamous, I don't need testing. Remember that you may be monogamous, but your partner may not be, unless you're in physical contact with your partner 24 hours a day. You don't know what your partner is doing. So I highly encourage women of all ages, whether or not they're in a monogamous relationship or not, maybe not every year, but to have intermittent testing for STDs. It's important to use condoms. We also talk about genetic testing now. There are genetic tests that not only increase your personal risk of cancers, for example, the breast cancer gene, but there are also genetic tests that we can do to see if you have a genetic abnormality that you could pass to your child, and that may alter your reproductive plans. We also talk about regular exercise, wearing your seatbelt, getting your vaccinations, your Tdap vaccination, as well as your flu shot every year. And then the final group of women I see typically are women in their 40s to 60s. They're still getting their Pap tests and HPV tests every 5 years. After the age of 65, it is not recommended to get Pap tests anymore, although I still tend to do it myself. We talk about getting bone density testing. You're in an age group now where you're increased risk for getting osteoporosis. We also talk about the zoster vaccination and getting thyroid screening. As far as mammograms are concerned, it is recommended that you get a mammogram every year, starting at the age of 40. Although breast exams are important, the mammogram is probably a more important exam. If you're at the point where you can feel a lump on exam, unfortunately, you may have a very advanced breast cancer if you can actually feel something. So you want to get a mammogram because we might be able to pick up breast cancer in an earlier stage, which can mean better treatment and more likelihood of survival. All right. As far as birth control options go, I'll just kind of focus on non-hormonal methods. You have sterilization, both male and female sterilization. Male sterilization is probably a better option than female sterilization, mainly because male sterilization is an outpatient procedure that's done in the office, as opposed to female sterilization that is more invasive and involves general anesthesia. Male sterilization is also slightly more effective and more easily reversed if your circumstances were to change in the future, and you might hope to have your sterilization reversed. Then condoms. another very good non-hormonal method. It's not as convenient, but is extremely effective not only for birth control, but for reducing infections, just as long as you use it every time. Very effective. We also have what we call the natural method or the rhythm method, and that entails monitoring your cycle and having intercourse on specific days of the menstrual cycle. One prerequisite for using this method is having a very reliable and predictable menstrual cycle. So unfortunately, if you're a woman who doesn't have a predictable cycle, this may not work for you. If you're a typical woman who has her cycle every 28 days, for example, you might expect to ovulate around day 14 or so, but it could be a few days before, it could be a few days afterwards. So in a typical woman who has a 28-day cycle, who might ovulate around day 14 of her cycle, that would mean you would have to abstain from intercourse, maybe beginning around day 10 to about day 18 of your cycle. To day 18 of your cycle. For the final part of the presentation, one more thing. We're going to also talk about what you can do to increase your fertility. One of the most important things I would recommend for boosting your fertility is, number one, not smoking. Also trying to maintain a healthy diet and a healthy weight. Probably the most important thing you can do to maintain your fertility is being of a normal weight. I see many, many women who come in for infertility. Unfortunately, many of them are overweight. And I talk about, maintaining a healthy weight. It's easier said than done, but many women will not need my help if they are within a normal weight for their height. There are testing options as well. We can do an FSH test, which some people call the menopause test, which can give you an idea of how close you may be to menopause. As you get closer, fertility is compromised. There's also a test called AMH, anti-Mullerian hormone, and that tells us about your ovarian reserve, and can tell us about the number of eggs you have left and the chances that fertility medication might work. We also look at prolactin and another test called TSH, as prolactin, as well as abnormalities in the TSH in your thyroid can cause infertility. One more vaccine I wanted to touch on would be the Gardasil vaccine, or the vaccination against HPV, as we talked about. It used to be available to only females aged 19 to 26. Now it's available to males as well as women in their 40s, as this vaccination can markedly decrease your chance of not only cervical cancer, but genital warts. And I'll now open it up for questions.
All right, thank you, everyone. So some people are not muted. Can you make sure that you are on mute and present your questions in the chat box, just to allow for better flow of questions. Thank you, Dr. Linda Matheson. So I'm going to, for those of you who signed on late, we have about 10 participants now. Before we had less. This is recorded, and so I can send you the recording of the presentation if you weren't able to listen to the first part. So I'm looking for questions, and I don't, let's see here. Can you talk about the recovery of male versus female sterilization?
All right, so male sterilization is done in the office under local anesthesia. So you would go home the same day, and you might be sore for a day or two, but there's pretty much no recovery. You can return to your activities pretty quickly. I don't know the details of male sterilization because I don't do it, but the recovery is much easier for a woman It does require general anesthesia. So that means you're put to sleep. An incision is made typically in the belly button through which a camera is inserted. Air is put in through this opening as well as light. And we take an instrument and block both of the tubes. There are many different ways of doing that. After the procedure, the air is let out. You're awakened. You're taken to the recovery room. And you go home after that. The recovery can take up to about a week due to soreness, but it's still a pretty benign and easy procedure to go through.
Okay. And I think you said the recovery is faster for a woman, or is it faster for a male?
For a male. For a male.
It's faster for a male.
For a male. So even when a patient will come to my office for a sterilization consult, and sometimes they're taken aback. They think I'm trying to talk them out of a tubal ligation, but I want them to know all their options and know the risks and benefits of all of them. So I do encourage them to get male sterilization, or at least bring up the topic, because many women are unaware of male sterilization and how it's a much easier procedure for a man. And some people leave saying, I'm going to encourage my partner to do so. And then some women say, we've already had this discussion, my partner's not interested, and that's why I'm here today to look into having being sterilized myself.
Okay. Someone wanted to verbally ask you a question, so I'll give them permission. Somebody wants to ask a question instead of typing it. Go ahead.
Okay. Linda, I always have 1,000 questions. Okay, I wrote them down. Okay, so the first question is, can HPV disappear? I was in the GYN office some years ago, and I saw a pamphlet that's like, you can have it this year, or you could, and then like next year you cannot have it. Like once you get it, does it stay with you forever, or does it dissipate within I heard 1 to 2 years.
Okay, excellent question. My patients are always shocked when I tell them that if HPV is gone. That's one of the biggest myths. So there are viruses that don't go away. Herpes, HIV, for which there is no cure. Just like when you have the cold virus, there is nothing that you can do to get rid of your cold. You can treat the symptoms, but it has to go away on its own. HPV usually does go away on its own. So what do we do when you have HPV? So if you're over 30 and we do your Pap test, your Pap is normal, but you happen to have HPV, we do nothing. And we repeat the Pap test the next year. If the following year you still have it, then we do further testing. The only exception to that is if you have one of the more concerning strains of HPV. There are many different types of HPV, hundreds, but 13 are associated with cervical cancer. Of those 13, 2 of them, 16 and 18, are more highly associated with cervical cancer. Just because you have 16 or 18 doesn't mean you will get cervical cancer, but 75% of women who eventually have cervical cancer happen to have had either 16 or 18. So if your Pap is normal and you have HPV and you don't have 16 or 18, we say, we'll check you next year. If you have 16 or 18, we go straight to a procedure called a colposcopy, which is what my patient had, the 32-year-old. She had 16, which is why we didn't wait a year to see if the HPV went away. And she had 16, and we did a colposcopy, and the biopsy showed cervical cancer. So yes,
so that leads me to my follow-up question. You were saying that sometimes they don't give a Pap, they only give, so HPV is the only thing that causes an abnormal Pap smear?
99% of the time, yes.
I didn't know that. Okay, so
yes.
Okay, so if your Pap is abnormal, it's probably because you have HPV.
Correct.
Okay. Okay, and my other question was the difference between a diagnostic mammo and the other mammo. I forgot what the other one was, but I had 2 mammos one year. One was, what are the 2 different types of mammo?
Okay, so basically you have screening tests and diagnostic. Just like when we do a Pap test is a screening test, and if it's abnormal, I do a colposcopy, which is a diagnostic test. Same thing with a mammogram. A mammogram is a screening test, and if it's abnormal, we do a diagnostic mammogram, which just means a mammogram that has more depth and more images for example, to
Okay,
get more
because I had to
information.
have that, and I'm just wondering, like, why couldn't they find the thing the first time? Like, why did I have to?
Because it is not, so a screening test by definition is a test that you can give to many people that is inexpensive. For example, the best test actually to check for breast cancer is an MRI, but it would not fall under the category of a screening test because it's too expensive. So it would not be economically wise to do all these diagnostic images on women, many of whom will turn out to
Would not have anything.
cancer.
Okay.
Right.
Okay.
Wow.
That was my 2 questions for now. Thank you.
Those were very good questions. Another question is the chance of pregnancy reduced if you have intercourse 2 days after your menstrual cycle? And I've heard of that as well, that those who are trying to not take a hormonal contraceptive with doing natural cycle, the best time for intercourse, they say, is 2 days after. Is that true?
2 days after your cycles
2 days.
ends?
So let's see, is the chance of pregnancy reduced if you have intercourse 2 days after your menstrual cycle?
See, when I talk about the number of days, it has nothing to do about with when it cycle ends. It more has to do with when your cycle begins. So that's why we ask, when was the first day of your last cycle? All of our information has nothing to do with when your cycle ends. So I really can't answer that question. It really has to do with when your cycle begins. So if that person can reframe the question, but have it relate to when their cycle begins, I can answer, but I can't answer based on when your cycle ends, because that doesn't mean anything.
Okay, sorry. So she said, thank you for, is there a chance you're pregnant 2 days after your 2 days after your cycle ends? Right. So okay. So she says she had to ask you again. She said after your cycle ends. So it's still,
that doesn't mean anything.
It doesn't mean anything. You have to know when it starts. So
when it starts, everything is based on when your cycle. Like when you ovulate, you probably ovulate about 14 days from when your cycle begins. It has nothing to do with when your cycle ends.
Can you give us?
It has nothing to do with the number of days of flow. Has nothing to do with the end. It really begins. It really depends on the day your cycle starts.
Okay. Can you give us an example with a calendar saying, like, if your period starts June 1st?
Right. So if your cycle starts June 1st and you have your typical 28-day cycle, you would expect to ovulate around July 15th, which is 14 days from July 1st. So if you're going to ovulate around July 15th, then I would probably abstain from intercourse beginning from July 10th to July 19th, a few days before, because you don't know when you're going to ovulate. That's the problem. Even though your cycle length may be 28 days, you won't know how long your cycle length is until you actually get your next cycle. So you're looking at that retrospectively. So you may think your cycle, you may say, okay, my cycles are usually 28 days. So if my cycle starts on July 1st, my next period I would expect to come on July 29th. So I'm probably going to ovulate on July 15th. What if that cycle is going to be 24 days and not 28? So you wouldn't ovulate on cycle day on July 15th, which is cycle day 14. You might ovulate maybe on July 10th. So you have to take that into consideration, not knowing exactly. You know how long your cycle, you don't know how long that cycle length is until your period begins. Then you can say, yep, my period began. So if you had a period on July 1st and the next one was July 29th, then you can say retrospectively, my cycle length was 28 days for the one that passed, but you can't predict or know that the next cycle will also be 28 days.
And I have a question. This may be very obvious, but when you say start, at what point of your cycle do you consider start?
So the day of a good flow. So some women have spotting for a day.
So starting is when bleeding begins. That's what you're
correct.
Considering as start. I just want to make that clear.
Correct. Yes.
Okay. Let's see if we have any more questions. As far as the fertility, no, as far as the natural cycles, taking your temperature and checking for mucus, does that help decide when you're ovulating? There is some technology out there currently called natural cycles. I'm not sure if you guys are aware of it. Natural Cycles is an app you could download on your phone, and you have to pay for the feature. They send you a special thermometer, and they send you some other tools that you can use, and it is FDA approved. Again, it's not 100% effective. It's about, I believe, 97%, 97% effective, which is similar to a lot of hormonal birth control. Dr. Matheson, what would be your recommendation or your maybe comments about something such as this, natural cycle monitoring with a calendar app and a thermometer? What's your thoughts on that?
I mean, I think if you want to avoid hormones and you have a regular cycle, so if you want to avoid hormones and you have a regular cycle, and more important, you have to have restraints, because basically you are basically not able to have intercourse for maybe a good 2.5 weeks of your cycle. So if you have a 28-day cycle, remember, you might be bleeding for 7, 8, 9 of those days, possibly. Not that you couldn't have intercourse during those days. And then there's probably a good 8 or 9 days of that cycle where you cannot have intercourse to avoid pregnancy. So I think the biggest obstacle to using a natural method is having the restraint to do so. But it's definitely doable. You know, all of those things, you know, in addition to monitoring your cycles, monitoring your temperature, monitoring your cervical mucus, those are all things that can help you best avoid intercourse to avoid pregnancy. But they're not 100% reliable. So I think it's still a very good option, but I said you just have to have a regular cycle, have restraints, and you know, in order to use use it.
Okay, thank you. Let me see if there's any more questions in the chat box. Someone says, what causes a woman to get her cycle twice in a month? Is there anything a woman can do to regulate her cycle?
Okay, so I'm going to dispel a myth. It is impossible to have a cycle twice a month. A menstrual cycle is different from bleeding. Just like how women say, I was pregnant and I got my period once a month. That is not possible. A menstrual cycle is the complete shedding of the lining. So that is not physiologically possible to have a period. Now you can have bleeding, but not all bleeding is what we call a withdrawal bleeding. So if you're having bleeding twice a month, it needs to be investigated, but you're not having a menstrual cycle once a month. But what could cause bleeding twice a month? It could be due to an infection in the cervix. It could be due to uterine cancer. It could be due to a hormonal imbalance, many different things. But you can't have a menstrual cycle twice a month. Another thing I wanted to mention was, I'll have a patient sometimes say, I got my period twice in July. And I'll say, what were the dates? Well, my cycle started on July 1st, and then I got my next cycle July 25th. And that is someone who has, for example, a 24-day. If you have a 24-day cycle, you could expect, if you got it on July 1st, the next one would be July 25th. Now, that is a normal 24-day interval, but you still had it technically twice in the same calendar month. That makes no difference. I'm not really concerned with whether or not it happened in the same calendar month. I'm more concerned of the start of the 1 to the start of the next. Some patients also say, my cycle always comes around the second or third of the month. That is impossible. If you have a 24-day cycle, you cannot have your cycle the second or third of the month because every month is different. That is physiologically impossible to have it because your body doesn't know the calendar month. It's not possible. As a matter of fact, if you have, for example, a 28-day cycle, it's going to come maybe July 1st, then July 29th, then maybe August 27th, September 20th. It's going to actually change from month to month, but it's never going to be the same calendar day every month.
So someone said it's not normal to have 2 periods.
No.
Bleeding in a 30 days period. 30 days.
See, I don't like to use the word month. Do you mean if someone says I had my period July 1st and the next one started again July 29th, 28 days have elapsed, and that's normal. The fact that it happened both in July is irrelevant. I want to know how often is it happening. If you say I have my cycle every 24 days or every 28, that's perfectly normal. If that happens to fall in the same month, that's okay.
I think the question she had within 2 weeks. So it's not normal to have 2 periods of bleeding in 30-day period, and then she says within 2 weeks.
That's not normal. No.
Okay. And the reason for the abnormality or the reasons you mentioned, the infection, hormonal.
Could be an infection. Yeah. It could be a side effect of the birth control pill. Some women have breakthrough. Some people have a Marina Iud, and you'll have irregular bleeding from that. It could also be uterine cancer. The most common symptom of uterine cancer is bleeding. Depending on the age of the patient, I may or may not be concerned about the possibility of uterine cancer. If a woman in her 40s has a period twice a week, I'm going to be twice in the same month, I'm going to be concerned. If a woman in her 20s has bleeding twice in the same month, I might approach it differently.
So at 40, does that give you a higher chance of cancer versus 20?
Yes. As a matter of fact, if a woman in her 40s tells me she had bleeding twice in 2 weeks apart, she has to have a biopsy of her uterus for me to make sure she doesn't have uterine cancer. That's automatic.
Okay. And I know we didn't address this, but for postmenopausal or perimenopausal women, bleeding, starting and the stop and start of bleeding or period irregularity during those times, is that considered normal?
So let's talk about what is normal bleeding as a woman approaches menopause. So the average age of menopause is 51, meaning most women have stopped bleeding around the age of 51. Prior to that, that may be 10 years or 5 years or 2 years, your cycles actually become shorter. So a woman may have her period, let's say every 28 days, and it's going to start to shorten. It may happen every 25 days, then every 24, and then every 23. And it should never be as short as every 21. Then after a period of time, it starts to space back out again. It may now come back to every 24, 28, 30, 40, 60, every 90, and then it will eventually stop. That is what is considered normal. Anything outside of that is abnormal and might require a biopsy or further evaluation.
And someone asks, is there a test for menopause? Can you test someone, a diagnostic test or some kind of screening for menopause?
So there's the FSH test, but that is not as reliable. The FSH test, even if you're 50, and we know, I don't need a blood test to tell me that anyone in her 50s is perimenopausal. So you could be 50 and you could still be having monthly cycles, but you are still perimenopausal and approaching menopause. And the FSH test.
Can you please mute?
Mouse.
Hello.
How you doing?
Can someone mute? Oh, hold on, let me see if I can control mute.
No. What did he do?
Nothing. He was running around. He scared me.
That's Michelle.
I just
Can someone
walked out and it was like open this much. I was like, please don't run.
Oh, wow.
Oh, okay, let
Give
me.
me 1 second.
Oh,
Okay.
I started dying. Started dying.
Trying
That's not
to-
Michelle, by the way. Not this
Oh,
Michelle.
it's not. Oh, okay. It sounded like you.
All right, I think I
I think
muted.
that's my friend Crystal. I
Yeah.
was gonna text her, but I see that you muted her. Okay.
Okay, yeah, I just mute. Yeah, I mute everyone that I thought was on, but more people came on, and I thank for everyone that joined us today. I think we have another question. How is Marina installed? How's it placed?
So you come into the office and you go into the stirrups just like you would do for a tap test. And the Marina IUD comes in an inserter, and we simply slide it to the top of the uterus and release it. It literally takes, I mean, unless there's an issue like the cervix is too tight or the woman is too nervous, it literally takes 5 seconds.
Do you need
5 to 10
Do
seconds.
you need medication?
No.
Okay.
Now it can be challenging if the cervix is tight. It tends to be, or in a woman who's never had her cervix dilated. So if a woman has never had a vaginal delivery or she's young, it may be of a challenge. So even if she's had a couple of deliveries, but she's never had a vaginal, she's only had C-section, it may be more challenging. Or if she's young, it can be more challenging.
Mm. And how would it affect your period? I guess she's trying to ask what are the side
Marina?
effects? Yeah.
The Marina affects it in a beautiful way. There's a very good chance that your periods will stop altogether, and I personally think that's wonderful.
Okay. Someone asked, back in the day, only women who had a baby could get an IUD. So that is not the case anymore?
Beautiful, excellent question. Beautiful question.
Mhm.
When I was a resident over 20 years ago, to get an IUD, you had to have had at least one child, and you had to have a child. You had to be in a stable relationship. So if you said, well, I'm single, I just want to have it, or I have multiple partners, you couldn't get it. Additionally, if you had an STD in the recent past, you couldn't get it. And this was all because the IUD was associated with infertility. So the reason why they wanted you to have one baby was because they figured if the IUD caused an infection and you could not have children, at least you had one. They wanted you to be in a monogamous relationship because they figured if you're in a monogamous relationship, less likelihood of getting an STD, which could cause scarring and infertility. Nowadays, it is completely and totally different. First of all, and the reason why infertility was associated with the IUD was because there was a defect in how the IUD was made. The IUD is attached to a string. This is the string that we use to actually, for you to put your hand inside so you can palpate the string and feel that it's present in case it has fallen out, which is extremely rare. But also we pull on the string to remove it. The string that they used to make, it used to be braided, literally like 3 braids. And that braid led to the bacteria would get, trapped in the braid. So the bacteria would just travel up the braid into the uterus, cause an infection, cause PID, and cause sterility. The string now is monofilament, mono meaning one string. So the likelihood of an IUD causing an infection leading to sterility is almost 0. That is how far we have come. So now, before I inserted it, the patient, not only did she not have to have a history of STDs, we had to do an STD test on her maybe a week or 2 before. We had to have that on the chart, and then she would have to come back. Now, there is no STD testing. She doesn't have to be monogamous. Even if she gets an STD with the IUD in place, we'll just treat it and move on. Before, if you had an STD while the IUD was in place, we would have to pull it out. Now, STDs have no bearing on it whatsoever. You have an STD, we leave it in, we treat it. You can be single, you can be 13, you can be 14. The risk of an infection by an IUD I personally have not seen it myself since the Marina and these new IUDs have come out. So there's nothing to worry about as far, I shouldn't say nothing, but it's highly unlikely that an IUD is going to lead to infertility.
Okay. Someone asks, which is better, the Marina IUD or the Paraguard?
It really just depends on what you're looking for. The Paraguard has no hormone, and there's certain reasons certain women may want to avoid hormones due to underlying medical conditions, or just a fear of hormones, or some people are just very sensitive to hormones. They may get moodiness, irritability, or depression. The hormonal IUD, be it a Marina or a Kylina, that hormone not only decreases pregnancy, but it also affects your cycle. Most women with a Marina IUD eventually stop having cycles and eventually have no menstrual cramps. So I guess it depends on what you're looking for. Do you want a birth control that also you have no bleeding and no cramps? Or do you want a birth control that is also highly effective, but you will continue to have bleeding and continue to have cramps? It's really just what you would prefer. I think the answer is it's self-explanatory, which option most people go for.
Okay.
99% of the IUDs I put in are the Marina, the hormonal.
Interesting. We have more questions coming in. So how would the Marina affect hormones? I think you addressed that. Marina is a hormonal, Paraguard is no hormones, right?
Right. And some women, I have some, the Marina hormonal IUD is meant to work just in the uterus, but there's small amounts that are absorbed into the system. And there's some women who say, I get acne, I'm moody, I'm depressed. And then, and some women just they have that sensitivity. And for those women, it needs to be taken out.
Do you screen for, we have another question. Do you screen for depression before this, or can you, I guess you would have to have them get screened if you have thought the person was high risk or something like that? I don't. Okay. The only patients in whom I don't recommend a particular birth control because of depression would be the depot injection. If you have a history of depression, I don't give the depot injection because it can make it much worse. Other than that, I don't screen for it. Excuse me. Okay. I'm sorry about that. Another question. Is Marina the 5-year one and the Paraguard the 10-year?
Correct.
And
that's correct.
That is correct. Okay. And I think someone else has another question, and I'll be waiting. I think they're typing it up. Someone else said they have another question. I think they're typing. So for those that missed the presentation as we're waiting for more questions, this is recorded, so we can send out the recording. The other question is,
well, while you're waiting, I think I touched on it during the presentation, but I wanted to remind everyone that when you go for your yearly exam, you should be screened for genetic diseases. I had a patient, she is she 33 years old? Because of genetic testing that I asked her, I thought that she was at increased risk for breast cancer. And she had the genetic testing and she had the BRCA gene, and she opted for a bilateral mastectomy. And she had one child at the time, and she said she's so happy she had both of her breasts removed because now she knows at least she will be there for her child and not have to worry about dying due to breast cancer. So that is, I feel, a standard part of the exam now. All patients should be screened for genetic diseases during their routine exam.
Okay, someone wants to ask a question verbally. I think I unmuted it.
Yes, you did. I was just waiting. Okay. Hi, everyone. So my question is, if you miscarry, what should you expect or be concerned about months after?
Good question.
Nothing really. I mean, if you have a miscarriage and you pass things naturally, there's no reason to think you'll have any trouble conceiving. If it's just the first time, there's no reason to worry about it necessarily happening again or having, problems getting pregnant subsequently.
I see. Thank you so much.
Sure.
Okay. And while we're waiting for another question, someone has another question. I want to touch on what Linda mentioned about infertility. 30% of infertility is linked to weight fluctuations or extreme weights, I would say, like if your weight is on the higher end or the lower end. And that's where a registered dietitian comes in. OBGYNs, obstetrician gynecologists, their role is not to help people lose weight or to change your diet or anything like that, anything of that sort. That's the role of a dietitian. So I implore you that I encourage everyone that is having any fertility issues to seek out specialists in the field that can help you with whether it's getting your eating your meals on cycle to match your likes and to match your energy level and to just give you overall healthy weight to help you ovulate the way that you need to and increase your fertility. So that's just one thing I wanted to mention to everyone that Linda mentioned about weight. And Linda, what do you do if a patient comes in and wants to lose weight? Do you refer them to a dietitian, or do you have a list of, at your clinic, a list of specialists that you would refer out to someone that, let's, for example, you found that they had blood sugars, they had insulin resistance, so their blood sugar, their fasting blood sugars are 200s or 300s. Well, that high, I guess you would have to admit them if it's 300-400s. But if they were, greater than 140, what would you do? Would you send them to an endocrinologist? I'm not sure.
I would send them to a nutritionist.
You send them to a nutritionist. Okay, awesome.
That's what I typically do, a nutritionist. Even
awesome.
Pregnant women. Sometimes my pregnant women are gaining a little bit more than I think they should, and I typically will refer them to a nutritionist.
Yeah. And so, and I thank you for that, because a lot of providers, sometimes they try to give tips and information, which is good, but you really should be going to a specialist in that field. Just like Linda said, she refers out for pregnant women. I see a lot of pregnant women in the diabetes clinic that I currently am a part of. And it's amazing how we catch a lot of deficiencies in vitamins, minerals, and so leading up to pregnancy, you need to get your diet evaluated, and most insurance companies cover that, and some may be out of pocket. And once you are pregnant, if there's concerns, you definitely want to follow up with a registered dietitian, nutritionist if you are having concerns with weight in pregnancy, or if you want to get pregnant again. So this is one of the reasons why we kind of highlight the importance of health for girls and women. Knowledge is power, and if you don't know, you won't seek out the advice and the help that you deserve. So Monica asks, are you in Virginia?
Yes.
Yes. And so I'm not sure, Linda, how you want to go about with questions. I know you were mentioning to me that you cannot give medical advice over the phone. I don't know if you want to touch that. Similar to myself, I cannot give medical advice unless you are a client and you sign a waiver. And we discuss.
Hold on. I'm Sue Ellen.
Yes.
Sue had a question that I also had.
Okay.
Linda, can you just get a genetic test just by requesting it? Like when you go for your exam, can you just say, I would like to have a genetic test?
No. So what happens is they fill out a questionnaire, and based on the answers to the questionnaire, I say you may be a candidate for genetic testing. And based on those answers, I then refer them to our nurse practitioner, who does the genetic testing. So you meet with her, she goes over your family history in detail, and then based on the answers, she has an algorithm that she uses, and we decide whether or not we should actually do the test. Bearing in mind, even if we think you're a candidate, your insurance makes the ultimate decision. They may say, yes, I see the answers, but we don't think your risk is high enough. The good news is the testing is so much more affordable. up to about 5 years ago, a company called Myriad had the patent on a lot of the genetic testing. And if a patient couldn't afford it, it would be like $2,000 out of pocket. A woman can have a complete genetic panel now for maybe $300. And we're not talking BRCA. We're talking the Lynch, which is associated with cervical cancer. There are ones associated with pancreatic. So even if you don't have insurance and you want it just because you want it, it's definitely more cost effective now.
Okay.
Hillary, that's a question that I wanted to ask. So in general, just any medical procedure, if you have the money and you want to have a test done, regardless of having insurance, can you have it done? If I can afford something, can I just have it done?
But you need a doctor's order. So if a patient says to me, okay, I know I don't meet criteria, but I want to pay out of pocket, absolutely, you can have it.
Okay.
Okay. So Linda, you want us to, for those getting yearly exams, which at the age brackets you mentioned when we should, and if those who missed it, again, she could go over that if you have a question, but when you go in for your yearly, we should be requesting.
So at this point,
test.
I think there's something called standard of care, meaning you wouldn't expect to not have a pap test when you go in for your yearly exam. You would think you were missing something.
Right.
And it is now considered standard of care to be screened for genetic disorders. It's not enough for them to say, what's your family history, diabetes, but you need to be, that's not enough. You need to be specifically asked, is your family of breast cancer? How old were they were diagnosed? And how many relatives? It has to be much more detailed than that. You should be getting that. You should be asked those questions.
All right. And so yearly PAP, HPV exam, and a genetic testing is something that we should be asking for, or it's standard of care and we shouldn't have to ask for.
Correct. It should be standard, right? Now, also, I have some women, especially my older women, who want a PAP test every year, regardless of the fact that it's not necessary. At this time, insurances are paying for it. And, you've got a woman in her 60s or late 50s who, as gynecologists, we hammered into them PAP every year. And they're psychologically, for them, it's like they're missing something. So I will still do the PAP. But thankfully that happens rarely now. I just give them the information. Most women are excited. Oh, really? They actually start to get off the table. They think that because they don't have a pap test, and I have to say, whoa, we still need to actually do a pelvic exam, because a pap test is just screening for cervical cancer. It has nothing to do with the actual pelvic exam. Your gynecologic exam is going to be exactly the same. Breast exam, pelvic exam, looking at the cervix, feeling the uterus, feeling the ovary. The pap test is just not going to be done on a yearly basis, which is simply swabbing the cervix. That just doesn't have to be done every year, unless you're high risk. There are different circumstances, but for the most part, it doesn't have to be done every year.
Okay, I think you just cleared up confusion for me. So the pap smear is literally the smear when they take
the smear.
Okay, so the pelvic exam, that's still sitting there with
exactly. Like
so
patients will say to me,
exam, what are you looking for in the pelvic exam?
Okay. So patients will say, they'll come to my office and say, when was your last pap smear? Oh, I had one when I was in the emergency room last week. People confuse the pap smear with a pelvic exam. That's like saying, when was your last breast exam? Oh, I had my last mammogram. A mammogram is different from a breast exam. The pap test is just one amongst many other things that we do. The pap test is simply, you look at the cervix and you remove some of the cells. What is a pelvic exam? A pelvic exam is, first, let me tell you what it is. So her legs are up in the stirrups. First, I look at the vulvar tissues, which are the lips. We look at the outside. I just had a patient this past week who hadn't gone in 5 years, and sitting right there on her vulva was a 1 centimeter lesion. And she just hadn't gone because she said, well, I have a hysterectomy. Yes, but you still have the lips. And she just neglected it. And you can have cervical cancer and you can have vulvar cancer, which we call VIN. It can be normal tissues. You can have VIN1, VIN2, VIN3, and then cervical cancer. And she had VIN3. And this could have been missed because she simply said, why? I don't have a cervix anymore. So we look at the vulvar tissues to make sure everything looks normal. Then we separate the lips. We look at the clitoris. We look at the urethra where the urine comes out. And then we look at the vaginal opening. Then we take a speculum. We put the speculum in. This allows us to look at the vaginal walls as well as the vaginal discharge. All the way at the top is the cervix. We look at the cervix and look at the discharge coming from the cervix. Even though you may not be due for a pap test, if I look at the cervix and I'm not happy with it, I'm going to do a pap test regardless. Then the speculum is removed. We place 1 or 2 fingers into the vagina, and then I feel the uterus, the mobility, the position, and the size. Then I move out to the sides and I try to feel for the ovaries. So that is a pelvic exam, which has nothing necessarily to do with the pap test.
Very important.
So, which is it that you said that you don't have to do, and at what age?
So you don't have to do a pap test until 21.
Right. But in a pelvic exam, you do for the rest of your lifetime as a woman?
Correct.
Okay.
But it depends. If I have some women in their 30s who are virgins, who don't use tampons. So a pelvic exam is very traumatic. If you're not sexually active and you've had a normal pap, I don't even do an internal exam. If she's not having a discharge, she's not having menstrual irregularities, she's not having pain, she's not active, I'm not going to put that speculum in there every year. For those women, I might space it out to every other year. It just depends.
Okay.
And that you do for a lifetime, like in your 60s, and you do a pelvic exam for your lifetime.
Right. Exactly. Mm-hmm.
Okay. That's good to know. Someone asked, is it safe to take probiotics during a pregnancy? I can answer that, but go ahead if you want to answer, Linda.
I mean, I think generally it is safe. I just don't know if it's going to be helpful. I don't think any harm is going to come of it, but I don't think there's going to be, personally, I'm not sure if there's any benefits personally.
And then I could add, so probiotics, they can come in different forms. You could take them as supplements, and you could live active cultures such as yogurt, fermented foods, other foods such as tempeh have probiotics, and those are helpful for the gut, which a lot of your immune system lies there. And probiotics sometimes can affect pH balance. As far as what you're eating and vaginal pH balance, I think that's another discussion we could have, another class that we could hold. But probiotics are, they are becoming more heavily researched. So there is some research on it. More is needed, but they do show hopes of helping the gut bacteria, which also helps, decrease inflammation and other GI symptoms, which are helpful for anyone, any age. So again, I'm not sure if they're talking about supplements or probiotic foods, but the foods for sure are good. The supplements, they depend on the amount of bacteria count that's in the supplement. But I'm not sure if anyone wants to send more detailed question. Did I answer that question? Someone sent it from the iPhone. I would also say always check if you're taking pills or like vitamins, supplements. You could always double check with your doctor. Bring them to your dietitian on nutrition visits, and we could take a look at them as well at your supplements. But as foods are good. I would say go to foods first before taking any probiotic supplements. Someone had another question. What can you eat to affect your vagina or discharge or smell?
Nothing. Nothing. I mean, certainly different foods can have different effects on many parts. It can affect the smell of your perspiration. Mm-hmm. It can affect your overall, but there's no food I would say specifically will affect your discharge. That is a big myth. I have patients say, oh yeah, I'm having a lot of discharge because I'm drinking soda or because I'm eating this or eating that. As far as I know, foods don't have a specific food that I can think of that will have a specific effect on the vaginal discharge or the odor. Now, you know, everyone is different and their body responds differently. But as a general no, there's some people say, you know, I have this odor because I had seafood or whatever. It's just not true. It's just not true.
Yeah, there's not a lot of evidence on the food you eat and the odor for sure. I know that hydration, water is important, or being hydrated. That could affect the dryness in your vaginal fluids. I know breastfeed and different things can affect your discharge, but the odor and the smell of the discharge, I feel like there is some pH balance within your stomach or your GI tract, and it possibly could affect your body. And there's more studies that are ongoing about what you eat and how it affects other parts of the body, like the vagina and the pH. So I guess that person can follow up with me one-on-one, and we could sit down to talk more about that. But like Dr. Linda Matheson said, there's not a lot of information on foods. There are some, but there's not a lot. And as far as odors, I'm not aware of odors. But I know that the soaps that you use, I don't know if Dr. Linda Matheson, you want to talk about this, the soaps you use, if you're doing perfumes, different things can affect odors. Odors that could be like a big topic in itself.
Well, I'm just gonna briefly touch on that. So
okay.
There is no need to use any feminine special washes, sprays, douching. The vagina is self-cleaning. I want to say that. Nobody has a special anal wash because they don't like that. So, and the vagina is not dirty. So there's no need for special soaps and washing. Those are just people who are trying to harp on women's fears and concerns and about themselves, but the vagina does not have a bad odor. If you feel it does have an odor, it needs to be looked at. Mm-hmm. If the vagina has a bad odor, it's likely due to an infection. Mm-hmm. No amount of douching, no amount of probiotics, washing, bathing will help. There's one vaginal infection in particular called bacterial vaginosis, or BV, that mm-hmm. causes a fishy odor, and the odor is very distinct. Other than that, there's no odor. When a patient comes into my office and she complains of a discharge, I actually smell the speculum. It's not a pleasant thing to do, but it's part of my job, and it actually doesn't bother me. But the vagina literally has no. Now you might notice an external odor, and that could be just from sweating and other reasons. But the actual vaginal canal has no odor, and if it does, you need to have it investigated because you probably have an infection.
Mm. Yeah. What can you do?
Okay, I have a question. I was trying to type it. Sorry, Sorel.
It's okay. It's okay.
What causes the vagina or the discharge to be acidic? Because doesn't the acidity go up or down?
What do you mean? What causes it? How would you know it's acidic?
Like when your panties are stained. I saw something online, social media.
Mm-hmm.
Or
so I don't think
say, you know, like if you have a panty that you've had for years or whatever, and it has like a stain, and because
that's normal. That's normal.
Right. That's what I'm saying. It's normal. But is it because the vagina is acidic? Like what causes it to stain the panty? Like I had a black panty that had like a white, like it was bleached, like it was stained. You know,
I don't think it has anything to do with the acidity. Just like how when you sweat, it discolors the armpit area of your clothing. It doesn't mean there's something wrong with the acidity. It just leaves a stain, and over time it makes a discoloration. But it has nothing to do with the acidity or anything like that.
But does the vagina get
Is there pH in the vagina? Is what you're saying?
Yes, there is. Yes, there is.
Okay, so can you talk about that?
Yeah.
Well, there are different things that can change the acidity of the vagina.
Right.
Douching changes the acidity of the vagina, which can lead to infection. A man's sperm can change the acidity of the vagina, because the sperm has a different acidity from the vagina, and that can change the overall environment. And unfortunately, that can lead to that BV infection that I spoke of. There are women who are in monogamous relationships or married who cannot tolerate the pH change from their partner's semen, and have to use a condom every time they have intercourse, or they'll get the BV infection.
Wow.
Right.
I have a friend who has a friend, she's not on here, so it's not her business. But she said that her friend's, like my friend's friend, was allergic to her man's semen. I didn't even know that could be.
Right. I don't think it's an allergy, but her vagina is sensitive.
Right. She got BV all the time with her man. So there's no cure for that? Like,
no.
Oh my God.
No.
There's no cure.
Some women just have to use condoms every single time. Any exposure to his semen changes her pH, and that changes in pH allows the bacteria to call BV to thrive, and it leads to that infection.
So there's nothing that he can eat to change.
No.
No. My gosh.
I have to study up more on this, but I have had some dietitians who or clients in working in the clinic that you can change your pH. I mean, just like your gut pH can change, your vaginal pH can possibly change with food. But again, they're doing more research on that. But I am not aware of BV being cured by food. It may help, but to be cured,
right.
Sure. Again, I love to do research, and I definitely will be talking more on this topic, and we're going to have a presentation on this topic because I know of a provider that wants to do something like this. But yeah, pH in the vagina is it's concerning, and so we're going to have to talk about this some more because I don't want to keep Dr. Linda too long. I'm not sure if can you answer more questions, Linda? It's one.
I can do maybe 5 more minutes or so if there are more questions.
Okay. Yeah, because we had about 11 people. We have 9 participants still on. So if you want to send in a few more last questions, and we'll wrap it up. No other questions? All right. I'm not sure if I introduced myself properly in the beginning. My name is Sue Ellen Anderson Haynes. I thought I believe I just jumped into the presentation and kind of introduced what 360 is, but I'm the founder of 360, and I love having presentations like this. I love giving knowledge and providing information to people, and I'm so thankful that I know Linda, my cousin's husband, and she's also like a cousin to us as well, to myself, and she's very helpful in providing information in our family. To be a really good backbone, I would say, in our family. I know I called her many times during my pregnancies to ask questions and tips. So very thankful for the job that she's doing. And I hope that you guys will also continue to join us on other presentations and look into services that you may need and to share with your friends. We are on Facebook. It is at 360 Girls and Women, and also on Instagram at 360 Girls and Women. And if you need to follow up with myself, I'll go back to the slide where email address is here. If you have questions, I could direct them to Dr. Linda Matheson, and I will
I just have one final note.
Oh, go ahead.
My final thing I want to say is at the end of the day, it is important to see your gynecologist every year. Mm-hmm. The gynecology exam is not just about the Pap test. We do so much more than the Pap test. We do breast exams. I examine the abdomen, feel the liver. I feel the thyroid. I feel the lymph node. We do a complete pelvic exam. We also check your weight. I also check your height. We also do a blood count for women who are menstruating to see if they're anemic. And there are things I have picked up, for example, diabetes in a patient who came in. I had once had a patient who had a ferocious yeast infection, horrible. And I said, she must be immunocompromised. And I said, let me just check your blood sugar. Her blood sugar was so high that it didn't even register on the machine. We had to get the booklet for the machine. And the machine said that her blood sugar was at least 444. And I picked that up simply because her yeast infection was bad. I see a lot of women with hypertension because we check the blood pressure. And I diagnosed hypertension just because they came in and it was high. So there is a lot to the gynecological exam other than the pap smear and the pelvic. Like the woman who had the vulvar lesion, she had been going to her primary care doctor yearly, and the primary care doctor missed that vulvar lesion, not understanding. So I just would say, you know, especially if you don't have a primary care doctor, be sure to see your gynecologist every year.
Yeah. Everything that you've said, Linda, you sound like you're very thorough at your exam. I know that I've been to doctors where they may have missed something or did it real quickly, or I am particular, so I always say, did you check this? Did you check my thyroid? Did you check that? Like, I'm always watching to see what they do. And some people, because I've moved to different states, they're not as thorough. And I'm glad that you're very thorough with your patients. But ladies, please find a good gynecologist. Make sure they're thorough. Make sure you get your tests and your answers. Make sure you get your questions answered. And if not, then you find someone that will answer them for you. Someone said, thank you all so much. Good presentation. Thank you. So I'm glad that you all enjoy the presentation. And I definitely would like feedback. If you receive a feedback form, go ahead and fill that feedback form out. Thank you so much, Dr. Linda Matheson, for answering all these questions. It's about 1:21 and we are going to end.
And how is the replay going to be available, the recording?
Okay, so for those that signed up that I have your email address, I will send it via email. I will send, the recording via email. Or through the platform, the healthy platform that I use. So keep a lookout basically at your email. You'll receive it one of those ways. All right. Let me see how I can. All right, so I'm going to stop the recording. Thank you, everyone, and have a good evening. Thank you. And do you have any final remarks, Linda?
Not all, other than just getting your yearly checkup, getting the most out of it, and also spread the word that because of changes in legislation, the annual exam, there is no copay. So there's unless you have, and of course, if you don't have insurance, that's something different. But and they took that away because they didn't want that to be a deterrent to getting your checkup. So there is no copay for an annual exam. So there's truly no excuse for not going in for your checkup, because if you have health insurance, it's fully covered.
That's good to know. Thank you so much. And I will pass the word along. So we are going to stop the recording. Thank you for coming, everyone, and have a wonderful day.
My pleasure. Thanks.
All right. Thank you. Bye.
Bye. See you later.
Bye-bye.